Hey there everyone again, it is Adam, and today we're going to be finishing up our section on urology. The first section we're going to be talking about today is going to be urinary incontinence. If you have this, you're in trouble. Urinary incontinence itself is considered to be an involuntary leakage of urine. It can be associated with some urgency associated with that as well. And so what we end up seeing is a lot of increased frequency both during the daytime and during sleep. Lots of kind of side issues that can come along with this, including self-esteem issues, depression, etc. We see that primarily females are going to be affected by this, especially around the time of menopause. Over a third of those women 60 years or older may be affected by this, and you can see that a lot of the chronic sufferers of urinary incontinence can lead to being institutionalized as they get older, simply due to the fact that it's very difficult to control. They may not have good home health care to kind of take care of them. So we know that the lower urinary tract is composed of the bladder, urethra, the urethral sphincter, and also some surrounding structures. And then you have the urothelium making up some of the kind of epithelial tissue there within the urethra. So looking more specifically, when we talk about drugs and where they're going to be working at, look at the neurophysiology is really important here. So specifically the detrusor muscle we see is innervated by the parasympathetic fibers. And so kind of what we talked a little bit about when we were talking about BPH and utilizing anticholinergics for the kind of the more chronic symptoms, kind of those irritative symptoms. What we're seeing here is that by targeting those muscarinic type 2 and type 3 receptors, you're going to be able to help kind of relax some of this muscle because it won't be have as much activation via the parasympathetic fibers. So you'll see the M2 is typically more prevalent, but certainly you'll see that the M3 receptors are going to be more responsible for those UI symptoms. Looking at the sphincter, obviously it has to maintain adequate pressure in order to maintain its closure. We'll see that the proximal sphincter is going to be more involuntary, whereas the distal one, you have more of the voluntary control over it. Looking at the bladder, obviously it's going to be accommodating increasing volume without necessarily increasing that pressure. And so if you have issues with that compliance, that can be a problem because then you're having increased pressure building, which can lead to urgency and lead to some of those incontinent symptoms. But normally what you end up seeing is that compliance is maintained by that smooth muscle relaxation. So it allows for the volume of the bladder to expand. And then there has to be kind of this coordinated effort between the different organs. And if you have disturbances here, especially in some of that neural regulation, that's where things can kind of be thrown off. So you have issues, either coming from the brain, the spinal cord, or even the pelvic nerves themselves may be affected. So one type of urinary incontinence we'll see is going to be the stress urinary incontinence. A lot of this has to do with urethral underactivity, so you're not able to maintain good closure of that sphincter. You typically will see it with brief bursts of activity, so either with say strenuous activity like exercising or sneezing, and essentially you're kind of overcoming those closure forces of that urethral sphincter. Usually what you're going to see is pretty low volume because again it's only going to be during that brief moment of increased stress. It's usually episodic. Obviously, things that can put you more at risk for it, including pregnancy and childbirth, menopause, obesity, and aging in general. It can occur in men, but typically this is going to be more related to things like related to surgery, post-op, and we can actually see it being aggravated by certain medications. So one thing we can see is that with the alpha antagonist, this can actually lead to relaxing of the smooth muscle within that sphincter and lead to kind of decreased closure forces. The other thing you can potentially see, and we've talked about before, are ACE inhibitors and angiotensin receptor blockers. As you know, you end up seeing that due to bradykinin buildup, they can cause cough, which may lead to some of the stress incontinence. Obviously, the ARBs are going to be less likely because they don't directly affect the metabolism of bradykinin, but you still can see it in some cases. Then you have urge urinary incontinence, which is going to be bladder overactivity as opposed to the urethral being a urethral underactivity. And so this is leakage associated with an urgency or desire to void. And so it typically is going to be related to this detrusor muscle having being too active and being squeezing too much down on the bladder. Usually it's going to be this involuntary type contractions. And again, it's not considered the same as overactive bladder disease as we've kind of seen before. The thing we have to look at is looking at the frequency versus the urgency. So again, this is going to be more related to the urgency or the feeling like they need to go versus just having to go a lot. Can be idiopathic in some cases, or can be related to some of these neurogenic detrusor overactivity. So it can be seen with certain neurologic disease, certainly if you have bladder outlet obstruction or aging. And then things that we can see worse than this would be things that would increase urine volume. So certainly diuretics, and also alcohol can be important for this as well, since it's inhibiting release of antidiuretic hormone, and so causes you to urinate more frequently. And then you have overflow incontinence, which can be urethral overactivity and or bladder underactivity. So what you end up seeing here is that leakage is due to the filled bladder, and basically it's unable to empty. And so chronically, you're going to be retaining more of this urine. So one of the things we saw with like BPH, in cases where you'll have that urethral hyperactivity is most commonly in BPH in men, but you can also see it in certain neurologic diseases. So specifically like a spinal cord injury or multiple sclerosis could be a problem there. Cases where you'd have bladder underactivity would be those in which the bladder cannot really completely empty, and so that can be seen with long-term bladder outlet obstructions. That's when we get to more of those kind of irritative symptoms we talked about with BPH. Certainly diabetes might be another issue as well. Again, just chronically causing damage to those nerves, kind of those microvascular kind of complications you see happening there. Some medications that can lead to urethral hyperactivity would be things like alpha agonists, or TCAs would be another one. So certainly like our first generation kind of antidepressants, so like things like your amitriptylines and nortriptylines. Things that can lead to decreased bladder contractility are going to include our anticholinergics. TCAs can do this as well, since they have a heavy anticholinergic component. Certainly our first generation antipsychotics, and then also certain calcium channel blockers, since we know that they work as smooth muscle relaxers anyway. On the vasculature, you can see the same thing kind of happening here within the bladder. So the presentation is going to depend on the underlying pathophys. If you see leakage that's happening in physical exertion, you're going to be thinking urethral underactivity. If you're seeing a lot of increased urinary frequency, a lot of urgency associated with it, then you may be looking at more bladder overactivity. And then with the overflow incontinence, you're going to be seeing more abdominal fullness, more hesitancy, incomplete bladder emptying, and so they may actually have frequency and urgency kind of at the same time. And then how we're going to be targeting our therapy is going to be depending on what's really bothersome to the patient. So is it an issue of the volume or the frequency of the urinations? Are they having to use things like absorbent pads or diapers and things like that to help control the symptoms? So we'll look at see how we can treat that with some medications. So our goals of treatment are going to include try to get good restoration of the continence, have a reduction in the number of UI episodes, and then want to prevent some of the complications. So again, things like having treatment here and treatment successes may help to prolong someone having to go into a nursing home. We know that there's lots of complications from someone going into nursing homes and things like that. In addition, we also want to help to minimize things like our adverse effects, decrease our costs, and then increase our quality of life. So kind of the same things you see in a lot of other disease states. So the general approach for our treatment, we'll see that medications can be used for patients who are not controlled with non-pharmacologic therapy alone. Oftentimes you're going to see both a combination of pharmacologic and non-pharmacologic therapy being used at the same time, since you can have some synergy there. And then based on the incontinent type, you're going to be choosing your drugs based off of that. So, and also looking here, you're going to be considering your comorbidities as well, as far as which medications may be more appropriate for your patients. Looking at non-pharmacologic therapy, obviously this will be first line. This is going to be better for mild to moderate symptoms. And this is going to be good for patients who maybe want to avoid surgery, avoid using medications if they don't have to, especially if they're more elderly and they're already on a lot of medications which may interact. If we can, we like to do things like behavioral interventions, try lifestyle modifications, doing things like changing their toilet scheduling regimens, changing when they're having fluids, before, say, they go to bed, if they're having a lot of nighttime symptoms, things like that. Sometimes you can get away with using pelvic floor rehabilitation, and then obviously, caregivers need to be active participants in this process as well to ensure success. So looking at urge urinary incontinence, medications we can use here are going to be our anticholinergics. So as we already mentioned, anticholinergics can exacerbate other types of urinary incontinence, especially the kind of the overflow. But here we can use this to help basically antagonize the muscarinic receptors, and we can kind of suppress those premature detrusor transactions. So it helps to enhance the bladder to relax and basically hold more volume before the patient gets that urge that, hey, I need to go to the bathroom. So all of these are going to be considered pretty much equally effective, and they're all going to have very similar side effects. So the big ones you see used here are going to include oxybutynin, tolterodine. Those are probably the two most common ones I see for this, but certainly things like sulfenacin or darafenacin are also quite common. So notice here that things like oxybutynin and also detrol or tolterodine come in these long-acting or extended release preparations, and so this is going to be useful to help decrease the number of time patients are taking their pills throughout the day, especially if they're already on a lot of medications to begin with. This kind of helps to simplify their regimen a little bit better. So again, anticholinergics for this urge urinary incontinence are going to be our first line medications we're going to go with. And again, a lot of different forms are available. So I already mentioned the long-acting forms, but certainly some are going to be more immediate release. In certain situations, if the long-acting doesn't really work for them, or if the cost is too much, or things like that. And then we even have transdermal preparations as well, which can be useful for those patients that maybe have a difficult time remembering to take their medications. Some of these patches will last for several days and will need to be changed every so often. Adverse effects, like you'd imagine to see, are going to include your anticholinergic side effects, and so that's going to be things like mad as a hatter. So you can see some CNS changes that can happen there, which can be especially troubling in your older patients. So especially if they're already having issues with cognition, this can be a big issue here as well. So that's probably one of the biggest things you're going to see. Obviously, you're going to be you can see things like red as a beet, so they can be having some flushing going on. They're going to be hyperthermic or dry. Hot as Hades. So these are all the things you're expecting to see. Dry as a bone. You're going to be seeing that dry mouth associated with that. So those are all very common things to see with these anticholinergic medications. So also consider, are they on other medications that are also having some anticholinergic properties? You can exacerbate that when you're adding kind of multiple medications that are all antagonizing those receptors. So contraindications, obviously if you're having urinary retention, you wouldn't want to add on another anticholinergic, but hopefully you're not having that if you're having this urinary incontinence. If they're having issues with gastric retention, decreased GI motility, certainly if they have things like gastroparesis, that's going to be worsened by these anticholinergic medications. Certainly uncontrolled narrow-angle glaucoma is going to be bad here as well, and then potentially myasthenia gravis. Those patients would be contraindicated from receiving anticholinergics as well. Again, like I mentioned, the mental status changes can be probably one of the more troubling things here, which may lead to discontinuation of therapy early, and falls obviously can go along with a lot of those mental status changes. Especially if you're having dizziness or increased sedation, things like that. So one of the big things to worry about there. So again, extended release preparations here are going to be associated with fewer side effects. One of the bigger, kind of more common annoyances you're going to see with these medications is the dry mouth. So typically when you're giving a longer acting medication, you're going to see lower peaks of the drug because it has kind of a lower plateau and it's going to kind of extend out throughout the day. So you're going to see less dry mouth there, which can be useful for your patients. With specific medications, looking at oxybutynin, this one does have a small degree of alpha blockade, so you do worry about the risk for orthostatic hypotension, which can make that fall risk a little bit higher for your patients. Again, oxybutynin XL, the extended release preparation, is typically used first line due to the fact that it's relatively low cost and it has a better adverse effect profile for the most part. Big thing with these extended release preparations, I don't crush or chew them because you end up breaking the extended release preparation and then you get all that drug at one time. So that's one of those big things to remember for these extended release preparations. You do not want to compromise the integrity of the product. Tolterodine is going to be another anticholinergic used pretty commonly. You do want to avoid using this in patients who have very significant renal dysfunction. So usually creatinine clearance is less than 10 mLs a minute, or severe hepatic impairment, since they will see accumulation and increased side effects. And it's also metabolized somewhat by CYP3A4. So if you have other inhibitors on board, you do want to reduce your dose of tolterodine here. Trospium is going to be another medication seen in the anticholinergic category. This one is a second generation anticholinergic, and one of the benefits here is that it has in its structure this kind of quaternary ammonium group, and so it has a positive charge on it constantly. It's not really affected by things like pH so much. So because it has that positive charge, it doesn't cross the blood-brain barrier. So the benefits here is it's not going to really cause so much of the CNS side effects as you might see with things like oxybutynin. So again, it's probably going to be more expensive because again, it's going to be a newer product, but that's one of the benefits of using this medication. It could be one to switch to if you're seeing problems with things like oxybutynin within your patients. Has fairly poor bioavailability, so it's really important your patients take this on an empty stomach. And then you also want to avoid this in patients with significant renal dysfunction, usually less than 30 mL a minute, because you can't see accumulation. Something else we may potentially use, not just for beauty anymore, but we can potentially use botulinum toxin. So again, this is a product that is derived from Clostridium botulinum. It's a very, very potent neurotoxin. It's probably one of the most potent toxins known to man. And what this does is basically paralyzes smooth and striated muscle by preventing the release of acetylcholine. So if you have patients who are kind of refractory to the other medications or they cannot tolerate other medications, you may be able to use this medication as more of an off-label kind of use. But what happens is essentially you're injecting the muscle, the detrusor muscle specifically, or the bladder, with this botulinum toxin. And so by doing that, you're preventing acetylcholine release unless you're having that detrusor muscle be much more relaxed than it would be otherwise. Duration of action is nice and long, between 4 to 8 months. So it can be something you maybe going for kind of an outpatient procedure every few months or so as symptoms kind of return. Adverse effects wise, hematuria is going to be something you see somewhat rarely, dysuria potentially. The other thing you worry about is going to be UTIs and urinary retention. Obviously, if your detrusor muscle is not really functioning quite so well because it's been paralyzed, you're more likely to hold on to that urine. So 20% of your patients may develop some urinary retention, which can lead to issues of its own. If you're having issues of urethral underactivity, therapy should really be focused on helping to increase urethral closure. And so estrogens are useful here because they're thought to help encourage proliferation of the urethral epithelium, help to improve local circulation, and then also to help increase the number and sensitivity of these alpha receptors in the urogenital area. And so by doing that, you're going to help to increase that closure of the closure force of the urethral sphincter. So some of the agents we can see used are the same ones we saw used in hormone replacement therapy. So certainly transdermal estradiol, conjugated estrogens, you can use vaginal creams. All these things are going to be useful as long as they're getting at least some systemic circulation to get to the right areas to work. You can actually see antagonistic effects by giving progestin, so I really want to focus just on estrogen products by itself. Again, some people feel it may be questionable efficacy, but certainly something worth trying, especially if there's a lot of that kind of stress and incontinence. And they find that usually the transdermal should be used most often because, again, it's going to provide nice, steady levels of activity and not something you'd see like a tablet where it may kind of boost up high and then kind of come down low and you may not be covered for the full 24 hours. So the transdermal seems to have a little bit better consistency there. We can also use some alpha receptor agonists, which may help to increase urethral closure. We used to use a drug called phenylpropanolamine, or PPA, but unfortunately this one, even though it was a direct alpha agonist, it was used for weight loss for a period of time and actually got removed from the market due to increased stroke risk. But another medication that might be utilized due to its effects on increasing levels of norepinephrine would be duloxetine or Cymbalta. You guys remember this from our depression lecture. You guys may think all the lectures are depression lectures, but really the one we talked specifically about depression, it's an SNRI, or selective norepinephrine reuptake inhibitor. And so it's actually approved specifically for stress urinary incontinence in Europe only, but certainly could be worth a try here. And essentially what it's doing is helping to facilitate that bladder to sympathetic reflex pathway and helps to increase that urethral tone. And of course, with the overflow incontinence, we talked a lot about that over in the BPH section, so please refer back to that. Okay, so this is the end of this section. It was pretty breezy. If you have any questions, though, please make sure you either send them to me or bring them up in class, and we'll continue on Monday. Thanks so much.